Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Rosa Maria Bruno, professor in clinical pharmacology at Université Paris Cité, Paris, France. At the end of this podcast, participants will be able to have knowledge of the updates and latest European Society of Hypertension 2023 and European Society of Cardiology 2024 guidance, be familiar with the new guidance on positioning of beta blockers in cardiovascular disease management, and be aware of the definition of and latest thinking on the management of resistant hypertension. This podcast is part of the continuing medical education program entitled Cardiovascular Disorders and Hypertension 2025 From Guidelines to Management, targeting clinicians, including cardiologists, internists, and general practitioners, nurse practitioners, and other healthcare professionals who manage patients with cardiovascular disease and hypertension.
Good morning. I'm Rosa Maria Bruno. I am a medical doctor, professor of clinical pharmacology at the Université Paris Cité in Paris, France, and I'm a hypertension specialist. I also collaborated to the writing of the last 2024 EC guidelines for the management of hypertension, and I will be happy to speak about this topic and other concerning resistant hypertension.
How may true resistant hypertension be diagnosed and differentiated from secondary hypertension or apparent resistant hypertension?
Resistant hypertension looks like a simple concept, but indeed it's not so easy. It's also difficult to define it really as a specific disease. We can define it more as an operational definition, which help us to identify the patients who are really at high cardiovascular risk and which deserve some special attention because they deserve a special workup for several reasons. So we put in this category of resistant hypertension individuals in which we are not able to achieve the expected target for blood pressure, so usually 140/90 in office blood pressure, with the use of at least 3 antihypertensive drugs, which usually are diuretic, a thiazide or a thiazide-like, renin-angiotensin system blocker, and a calcium sennol blocker. So if the combination of these 3 drugs at the maximally tolerated doses is not effective in achieving the blood pressure target, we can define these patients as a resistant hypertensive patients. What it is important is then what we consider a true resistant hypertensive patients, which is your question, because this is something that it's what we will discover in the workup of the resistant hypertensive patient. Because the first step is, since the definition includes patients who have high blood pressure levels, uncontrolled blood pressure levels with 3 drugs in the office, the first thing to understand is if this is confirmed by out-of-office blood pressure measures. This is why the 24-hour blood pressure monitoring is the first step to understand if a patient has only a white coat effect or it has what we can define a true resistant hypertension. But indeed, according to other definitions, other factors should be taken into account to define if a patient is a true resistant hypertensive patient or it is rather a pseudo-resistant hypertensive patient. And the most important thing that must be understood is that a patient may be resistant because simply is not taking the drugs in the way that have been prescribed. So adherence is something absolutely crucial that must be assessed in resistant hypertensive patients. Unfortunately, adherence is very difficult to explore because the questionnaires are not so good. Simply asking the patients may not give us the right answer, and the intuition of the doctors also usually fails in this case. So we need objective measures of adherence, And this is the reason why it's important that resistant hypertensive patients are sent to a hypertension specialist center. They usually have access to drug dosage screening in urine or blood. And this, of course, it's an objective way of assessing adherence. Another one is witnessed pill intake, which is also a technique that can be done in a specialized center. So I would say the first two steps of the workup of resistant patients are already defined with an ABPM and the testing of adherence. But of course, we may consider that many patients can simply have a poor blood pressure measuring technique, and so come up with very high blood pressure levels only for that reason. So also the methodology is something that should be assessed. In this way, I think we are defining more accurately what we can consider a true resistant hypertensive or a pseudo-resistant hypertensive patient.
What is the management and treatment of true resistant hypertension, ESH 2023 versus ESC 2024?
Luckily enough, in terms of resistant hypertension, the two guidelines are pretty similar. And this, I think, it's a very good thing. And what it is really important is that the resistant hypertensive patients need first some confirmation test to assess adherence, as we were already saying, and to assess the absence of white coat effect, and so a 24-hour blood pressure monitoring. So these two exams, we already mentioned it in the definition, but are the first step of their workup. Then the other important step that must be taken is the assessment of secondary hypertension causes. This is very important because a very large proportion of resistant hypertensive patients have indeed a secondary cause of hypertension, which can be assessed by some specific tests. So we need to perform some imaging test to exclude renal artery stenosis, blood test to exclude renoparenchymal hypertension. So if there is a reduced renal function as a cause of resistant hypertension, and we must exclude hormonal causes of hypertension, endocrine causes of hypertension. This is very important because a very large proportion of patients with resistant hypertension indeed have, for example, primary aldosteronism, which is the most common cause of secondary hypertension. Another important secondary cause of hypertension that must be taken into account is obstructive sleep apnea syndrome. This is hugely common in resistant hypertensive patients, and it's something that we really need to look for actively because it's not always symptomatic, and the detection of the condition, of course, can help in improving blood pressure control. Concerning the treatment of resistant hypertension, in this case, we must consider different options. Therapeutic management of resistant hypertension may be really a teamwork in the sense that depending on the main cause that we identify for lack of control of hypertension in these specific patients, we may decide a different strategy. So, of course, the first step is always reinforce lifestyle measures because increasing the adherence to a low salt diet, for example, may improve a lot the efficacy of currently administered drugs. So this is something that we might consider. Reduce weight or increase physical activity, of course, they have a antihypertensive effect per se and must be implemented in resistant hypertensive patients. If we identify a secondary cause of hypertension, we may decide to have specific treatments that may be interventional or pharmacological, which are specifically targeting that particular form of secondary hypertension. Then, in terms of improvement of adherence, there's a lot that can be done in terms of patient education, but also facilitating the task of the patient of taking their drug. So switching to fixed dose combination could be a very good option to improve efficacy of the pharmacological treatment. Then, of course, it's important to titrate the therapy. So if the patient despite all these efforts and these strategies we already mentioned, it still is not controlled with the 3 drugs at maximal dose, it's the time to add a fourth drug, for example. And the fourth drug for which we have the most important evidence is spironolactone. And so the category of the mineralocorticoid receptor antagonists are to be preferred as a fourth drug. And in this sense, both ESC and ESH guidelines, they have, with some nuances, the same approach. We have other drugs that we can add, of course. For example, we have beta blockers. Beta blockers are widely used in resistant hypertensive patients because these patients, they often have additional reasons to take a beta blocker, for example. So a specific cardiac disease, previous myocardial infarction or heart failure, or other condition that suggests that a beta blocker is recommended in this category. And so this is, of course, another therapeutic option that can be added in resistant hypertensive patients. We might consider also that both ESC and ESH guidelines consider the possibility of having a device-based therapy, which is renal denervation, recommended in patients with resistant hypertension. And this is very important because, of course, it may be useful, especially in cases in which we found no way to improve our blood pressure control with the traditional strategies. It is true that the procedure now is sufficiently safe and simple to be performed without particular problems. In any case, what guidelines recommend is that the indication for renal denervation is performed in a specialized hypertension center, and that the procedure is performed by an interventional cardiologist or an interventional radiologist with some expertise in the technique. Finally, we also have other drugs that can be added with a less degree of evidence, but they can be added in any case. So we have centrally acting drugs, we have alpha blockers, and another important thing to consider is that if we have patients with chronic kidney disease, we may need to switch to loop diuretics. So also in terms of pharmacotherapy, there are additional options that can be considered.
What are the significant comorbidities associated with resistant hypertension?
Resistant hypertension is usually, we can say, the end stage of a process of uncontrolled blood pressure over many years, and usually in very high risk patients, which means that many of these patients have indeed additional cardiovascular risk factors. The majority of them are obese, many of them are diabetic, many of them have chronic kidney disease, as we were saying, which means that these conditions are tightly related to resistant hypertension. For example, especially for chronic kidney disease, we can say that chronic kidney disease is a cause of resistant hypertension, but resistant hypertension, uncontrolled hypertension may also worsen renal organ damage, and so chronic kidney disease. Other important comorbidities, as we were saying, are the cardiac comorbidities, which are very common. And so many of these patients had already have a myocardial infarction, or they may have a heart failure, especially with the preserved ejection fraction. This is why these are patients that usually take a lot of drugs, and so the problem of adherence become even more important.
What take-home messages do we have at the end of this podcast?
I would highlight a few important messages. One is that resistant hypertension, it's not really a diagnosis. It's a way to spot the patients in which we must have much more attention on. And the other important message is that the first step of workup of these patients must be always the 24-hour blood pressure monitoring and the adherence test. And the third one is that these patients are complex patients. They are not so common. They are a minority of our hypertensive patients, but they are quite special. These are the patients that must be managed by a hypertension specialist team.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.